We now have Dr. Roisin Koshi. She's a physician who's finished her undergraduation and postgraduate from CMC Vellore, and she works at the Mukunda Christian Leprosy and General Hospital in Assam. Over to you, Roisin.
Thank you. I'm Roshan, and I'm a physician working in Mukunda Christian Leprosy and General Hospital in rural Assam. And over the next few minutes, I'll just like to share COVID care at Mukunda, the challenges, as well as the opportunities that are coming up in the coming months. This is where we are. We are in the Northeast. We're very strategically located at Karimganj district, which also borders Tripura and Mizoram. So we have a huge catchment population area. If you look at Karimganj district, it's one of the Barak Valley districts, and it's one of the most impoverished districts in lower Assam. On a non-COVID season, if our patients have to receive high quality tertiary care, they have to travel to the medical colleges, which on road would be around 6 to 12 hours. One of the decisions that the government of Assam and Tripura have made is that COVID care would be restricted to government setups. So mild patients who are COVID positive would be treated in the district hospital, while moderate and severe patients would be treated in medical colleges. In our district, Mukunda Hospital has been designated by the government as an isolation center, which means we are allowed to admit patients who are clinically suspect. Since August, we have been provided with rapid antigen tests. So we test these patients. If they are positive, we have the option of referring them to our nearest district hospital, which is 50 kilometers away. And if they're very sick patients, to Silchar Medical College, which is 160 kilometers away, around 5 hours from Mukunda. One of the greatest challenges and the question that was on our mind when the pandemic started is how much of a priority should COVID care take over non-COVID care in a resource-poor setting? And first off, it might seem like a very insensitive statement, but just to give the background that our district is one of the districts in India which has very dismal health statistics. So you can see that the MMR and the IMR is way above the national average. And we are a very busy hospital. We serve in this situation as a 190-bedded secondary level hospitals. We are a small team of 10 consultants and 6 junior doctors with all the major specialties, including intensive care, which is the only intensive care unit in the district. During the non-COVID season, it's busy with 400 patients seen in the outpatient per day. Throughout the year, our bed occupancies are more than 90%. We conducted around 6,700 deliveries last year and around 10 to 12 surgeries per day. So given this background, I think one of the great challenges that we will have as a primary healthcare provider in rural Assam is when government facilities are overwhelmed with a COVID pandemic, how much can we prioritize COVID care over non-COVID care? The second challenge has been to actually brainstorm protocols. The picture that you see on the right is a usual OPD day in Mukunda, which is a fairly busy day. And when the news of social distancing being the prime vaccine available, it was really a nightmare for us as a team in Mukunda. And I'm just sharing a small video clip to just give you an overview of from March till now, how things have changed a lot, and we've been able to streamline workflows in the main hospital, in the non-COVID areas, restrict patient numbers, restrict visitors to make it much more safe, both for patients as well as our staff. So the main hospital is a little away from the main road, probably another half a kilometer to reach the main hospital. It's an uphill road. We have staff triaging at the entrance. And that's the main entrance with the OPD registration. That's a main waiting area and a common room where doctors see patients. These are all the different wards, and the number of visitors are very less when compared to a usual Mukunda day. The labor room and the NICU functioning as normal. And I think being able to ensure that non-COVID care is not affected as much as possible has been a great challenge. And I think it will continue to be a challenge in the coming months as the pandemic spreads. The greatest opportunity I feel in rural hospitals.
Looks like Dr. Roisin has had some internet connectivity issues. We'll try and actually, we also have a video of the same presentation. We'll try and play the video from that point where she left off.
to say about their experience, to partner with others and to receive their support has been a great opportunity. We would like to especially acknowledge Azim Premji Philanthropic Initiatives who have helped us with funding of PPE. That's our team in the isolation ward with the resident doctor and 5 nurses who manage the whole setting. They do a tremendous job. We've had a BSc College of Nursing, which we were hoping to start this year, but the building has been vacated and converted into the isolation complex. Currently, we have 12 beds, with 4 beds on the suspect side and 8 beds on the positive side. The artificial intelligence software Curai is a free trial software that we're using for a few months to help us to flag chest X-rays which are suggestive of COVID. And this is just a screenshot of some of the patients which have been flagged. And all these patients who have been flagged are shown to be RAT positive. And in a busy place like Mukunda, where you have few doctors and a large workload, this software has definitely helped us to streamline the workflow as well as to make sure that we're not missing out on patients. This is again a short video clip to show our isolation complex being run by a resident doctor as well as a group of nurses who handle most of the work there, including collecting investigations, doing portable X-rays. Sorry. It's a BSc College of Nursing building. The structure and the process for how the patients are being managed. These patients are absolutely dangerous. The second opportunity has been to be able to see how the situation is evolving, and we've had this opportunity to look at our data from August to the 3rd week of September. We've just looked at patients who have been seen in an isolation complex and who have had a rapid antigen test done. It's around 163 patients. And as you can see, at this point in time, a majority of our patients are managed in the outpatient department, while we are admitting only 40% of our patients or referring them. And this might change in the coming months. So one of the things that we wanted to do is to look at our data on the patients who were admitted. So there is a table showing the clinical profile of such patients who are admitted with symptomatic COVID illnesses. So that's around 40 out of 65. So a symptomatic COVID illness is a patient with fever or cough or breathlessness or GI symptoms and who has had a RAT test done. The remaining patients out of the 65 are patients from the main hospital who are incidentally detected to be COVID positive and were admitted in the isolation ward. So if we just look at our data, we realize that almost 80 to 90% of our patients who are admitted in the isolation ward have moderate to severe illness, and only 3 patients were admitted with mild symptoms. Around 50% of them had belonged to the elderly age group, more than 50 years, and around 68% had at least one risk factor, the most common risk factors being diabetes and hypertension. What does it mean to the patient? It means staying in the hospital to an average of 4 days for moderate illness and 4.75 days for a severe critical illness. So I feel the numbers are a little skewed because of the referrals that we also have, but a severely ill patient who has been discharged from our hospital would stay up to 9 days in the hospital. What does it cost to the patient? What is the bill that they have to pay at the time of discharge? This is important to our subset of patients. For a person who has been moderately ill, the average bill that it would cost them would be around 10,692 at discharge, while for a person who is critically ill, severe illness would be around 30,000, and there's a range there. And in Mukunda, we are very committed to providing high quality care at affordable cost, and any patient who is economically disadvantaged has the benefit of getting free treatment. And this is going to be a concern for us, especially as most of our patients are moderately ill, severely ill, requiring oxygen. Oxygen supplies and the cost of oxygen treatment is something that we would be conscious of in the coming months. This is the outcome. We've looked at all the medical records and personally called up patients who have also been discharged or referred to find out how they're doing. And out of the 38 patients who we could contact, 70% are alive, they're doing well, while the remaining 30% have died due to the illness. As you can see, half of them were RAT positive, half were RAT negative, and 6 died after referral. Most of the patients who died belong to the severe category. It's been a great opportunity this last 3 months to be able to understand not just the challenges of a poor man, but also the challenges of a poor man during the times of a pandemic. And we feel that God has been showing us and teaching us that all that we need to do is to do the best we can with what we have with His help. And He has been faithful to date. We'd like to thank CMC Velo and the Mission Network for their concern and support, and we'd like to close by sharing a few areas we thought we could engage in the coming months. One is to enable us to learn from our own data of patients, to develop our own customized clinical guidelines, especially in the coming months as we have to manage this pandemic with a very lean team of health professionals. Would really like to appreciate all the webinars and sessions that have been going on about COVID and non-COVID at the end of a busy day and after troubleshooting a lot of issues in the hospital, to be able to just sit down and listen to someone talk about science of COVID, about the basic principles of treatment and some concepts that we need to keep in mind. That has been a really great blessing for us to formulate our own guidelines. And finally, if opportunity exists in future to include statistics as well as scenarios from mission hospitals for the health team and CMCs to be aware of, so that it can be useful for your training undergraduates and postgraduates as they complete their training and come and serve in rural areas in India. Thank you.
Thank you, Roshin, for that lovely presentation. Our last presenter is Dr. George Matthew, a medical director, Shanti Bhavan in Simdega in Jharkhand, an undergraduate and postgraduate from CMC, former principal of CMC, and now Mission Hospital doctor. Over to you, Dr. George.
Thank you, everybody, and good morning. I don't think I will repeat what the experience of many of the others who have shared this morning. Rather, to highlight a few issues that may be unique to the situation that I was in. At the end of March, we had a government order saying that under the powers of the Emergency Disaster Act, we were to be the sole COVID hospital for the district. In other words, there was no choice. It was a mandate that had to be obeyed. And at that point, we were not even thinking of COVID. So we had to truly jump into this fight without any preparation, any awareness, and any support. And it is God's grace and the support of a lot of my own personal friends and connections with the mothership, CMC Vellore, that helped us through this period. Many of the people who participated in today's discussion were part of the support group that I had, to mention people like Johnny Uman, Christopher Moses, not only on moral support, but many other ways to find support financially and materially to overcome this disaster that we were facing. Second was, we were a very small team. Like J.B. Peters said in the beginning, we were the foot soldiers. We were not like the battle tanks of Mukunda, Jalna Mission Hospital, and Visamkatak. We were literally the foot soldiers with hardly any resources. Just four of us, one of the four doctors with a part-time doctor and 15 nurses. And we had 60 beds and we were to start this facility. All that we were told by the government is that you start receiving patients from 4 days from the day the order came. And so we had to improvise, innovate, and also to look around, scrounge for material and also information to make ourselves ready. And that was a trying period, but with the help of God's grace and a lot of other support, we were able to manage. But the important thing was, as Johnny said, is to improvise, to innovate, and to modify whatever is available rather than looking for the ideal. So we managed with that. We made our own PPs, like you have heard the experience of many people. We did not have facility for non-invasive ventilation. We had only the choice between high flow oxygen or intubated ventilation, and we chose that we will not go on to intubated ventilation as much as possible. But we had to depend on high flow oxygen. Fortunately, we needed to resort to that only in 2 of those cases. Our team was small, so we had to include everybody from the doctors, nurses, clerical staff to the housekeeping staff as part of the team who did multitasking, and they rose up to this challenge. The stigma was significant and we had to evolve strategies to face that. We were the government hospital, so we were answerable to the government, and the goalpost kept changing day to day. But I must say that the government is doing its best. It is for us to collaborate with them and to strengthen their hands in trying to enhance their capabilities rather than finding faults with what is wrong with the government system. So it was the case in our district. We were the only center which had an ICU for 4 districts around, and the nearest other ICU was 130 kilometers away, which was 4 hours by road. So either we do something or the patient usually does not survive. We were able to involve the government doctors and nurses slowly, step by step, making them aware and building their confidence so that they can start looking after at least the asymptomatic or the mild symptomatic ones, which after a period of 4 months they were willing to do. So they started a holding facility, and then now they have a full-blown COVID care center. And since then, we have taken a back seat, agreeing that we will take care of the more complicated cases. That is a situation where we are. So I have some wish list for CMC now that we have gone through this experience. I do not want to repeat whatever the others have said. One of the things that would be useful for people who are like foot soldiers in the back of beyond in the remote areas is to have a facility of a hotline to CMC. Somebody who is there 24/7. You have a problem with a patient who you cannot manage or you are not confident, you are somebody to ring to and ask for advice. I think CMC must continue its training courses because COVID is going to stay for a while. It is here to stay. And I think the subsequent generation of CMC undergraduate and postgraduates must be well versed and confident of managing COVID wherever they go. In other words, they would be the foot soldiers of the future. So like every other disease, they should be confident of managing, of isolation, for quarantine, for treatment, for non-invasive ventilation, for COVID problems. Second is you would find that many of our hospitals have shied away from ventilating patients to have go up to the extent of giving them high flow oxygen or using drugs, but very few would offer ICU care with ventilated patients. It is because of the fear of aerosolization and staff contamination. And I think the alternative is non-invasive ventilation, and very few of us of the older generation have had experience with non-invasive ventilation. So the younger generation need to know that it can be done and how it can be done effectively. And I think everybody should be taught, irrespective of whatever course they pass through, that they have an experience of non-invasive ventilation. Perhaps CMC should think of conducting workshops either in CMC or regionally, where people from nearby mission hospitals can come and learn the skills for non-invasive ventilation. Lastly, I think CMC should set up a facility for updating what is current. There is so much, there is an information overload about COVID. You do not know what is relevant, what is not relevant. CMC should have a facility by which there is a current guideline or update which is put out periodically, so that what is the pragmatic, what is scientific is available for people to refer to. For example, we do not know how long the immunity lasts. In our own center, when we check for antibody levels of post-COVID patients, only 8 of them had adequate antibodies. Because there was a plan, government plan to start convalescent plasma transfusion, but you need to check. So what does it mean? Does it mean that people who have had COVID are prevented from getting reinfected, or should they be protected? Or is eternal vigilance the price to pay for protecting your staff, whether they have had COVID or not? These are guidelines that are badly needed. There are patients who become negative after 2 weeks. Some patients become negative, RT-PCR negative, after 7 days. Are there some rapid responders or slow responders? And what is this myth about reinfection? Do people really get reinfected? And if so, what are the risk factors in that? So these are things that I think CMC should proactively do as part of its training and dissemination, which would be very helpful to people who are in isolated locations. And lastly, we are all talking about vaccines, and there's a hype about vaccines. CMC should be proactive in providing information which vaccine is the most effective. If so, which are the groups of people who should be vaccinated first, and how many doses are required. These are the capabilities that CMC has to provide, and also to look at patients who are undergoing surgery. Do their body fluids have COVID in them? How long does it take for the body fluids to become negative for COVID? And is there any strategy to what is the reasonable waiting period after a COVID infection that they should wait for an elective surgery? So these are the kind of questions that CMC can answer. And I request that CMC continues its very effective training and educational program, apart from hand-holding and nurturing all the people in the remote areas and those who are struggling in the frontiers of fighting this COVID. Thank you.
Thank you, Dr. George Matthew. We were hoping that we would have time for some discussion and wind up. But I'm actually going to conclude today's session. It's not possible to summarize the varied and in-depth experiences that are happening in all these 8 centers. But some take-home messages that I can gather. The first and foremost is that care is taking place in remote parts of the country, and a huge amount of effort is happening. And hospitals are not just surviving, they're doing extremely well. Taking care of patients, most people surviving, diagnostics, labs, infection control, PPE, you all have seen it. The second challenge that is being seen is how to balance COVID and non-COVID care. And very nicely, it was brought out, patients who are not able to access treatment for TB, for HIV, for oncology. We also heard how we have to manage public perception to ensure priority for non-COVID care. A third area which we heard of so nicely, we heard masters of training, which is very key to the response, to team building, to maintaining motivation, to protecting the staff in this effort to handle the epidemic. And we heard from every place the need and the priority to work with the government, and as Dr. George Matthews said, to strengthen the hand of the government and different kinds of collaborations that these institutions have been able to employ in order to handle the epidemic. Each of those institutions have had a huge amount of reorganizing and reworking. And we also heard about a variety of innovations that are taking place from PPE to AI for X-ray, the 6-minute walk test, various ways to keep costs down. And these are all things that we are learning from. I think some take-home messages from CMC, I think, were nicely highlighted by Dr. George Matthew, and I will just repeat them because they're actually very important. And he said that we need to make sure that this is incorporated into our UG and in our PG training. We need to maintain all the training effort that we need to do, but we need to move further into things like NIV training. He also emphasized the importance of periodic and up-to-date information as new things are happening, and also the need for a helpline from CMC 24/7 to help with all these different challenging situations that are happening across the country. And I'd like to add here really is that we heard such a rich experience in the morning, but we need to document the different experiences that are happening across the country. So with these words, I want to thank all the 8 centers, which I know all these people actually working on the floor, looking after patients, and I want to thank them for sharing all their experience to all of us, which we have learned from, and to all those who helped organize today's meeting. So thank you to all the participants who are listening carefully, and I want to hand over now to Dr. Thomas Ram.
Dear friends, we hope and believe that these kind of sharing sessions will be extremely valuable for all of us in various kinds of institutions. And these sessions will lead us to have mutual benefits, help us to collaborate with each other, and as we heard, how can we strengthen the efforts of our government to fight this pandemic. I would like to thank especially all our panelists from various parts of the country in those remote mission hospitals and sparing the invaluable time and the rich experience, which I'm sure can be used all over the country during this pandemic. I would like to also thank our moderators, Dr. Anand Zach and Dr. Winsley Rose, for the excellent coordination, and also our support team, as we were worried that how can we make this session possible where people located in remote places and many people logged in from various parts of this country. So thank you, team, for that. So I'd like to also thank the administration of CMC, Director Dr. J.V. Peter, who came and shared some remarks at this point. Thank you for all the requests which were made on how CMC can strengthen not only our mission network, but various other partners in this country. And the suggestion of an NIV training and also a training based on the various case scenarios which we encountered during COVID-19 is underway. And when it is available, we will be able to share it within our network. God bless and stay safe, all of you. Thank you.
So the email is ccc.training@cmcvellore.ac.in. So if you have any, any training needs, any further things that you want to discuss, you can actually email that particular email. It's there in the chat box as well.
If you want to connect with any of the people who spoke today, we'll put you in touch with them.